Hey guys, Dr. Rosa. Just a quick hit video here to cover an Airway update to go over some stuff that we've been talking about on the EMS side about how we should approach Airway for the department, and just wanted to go over some very quick points here, and thought this would make a short and efficient video for you guys to take a quick look at. So first off, bottom line up front for just in case watching the whole video isn't your thing, but what I want to go over is when intubating, first pass success correlates with outcome. So really optimizing that first pass success is a very important part of what we do. We're going to play to win. We want to start off with video laryngoscopy with a Bougie or the dedicated rigid stylet. Bougie preloaded with endotracheal tubes, so you're not messing around with that. And then making sure that your patient positioning and the position of the operator is optimized when you start, so that you aren't kind of moving around and trying to correct stuff and having to have a second attempt. Don't forget the use of the supraglottic airways, because they're extremely fast, especially when we have multiple priorities going on and we just need to get the patient oxygenated and ventilated as quickly as we can. All these patients where we take control of their airway need end-tidal CO2 on immediately after control, because hyperventilation absolutely kills people. We see this in the cardiac arrest data. We see it in a bunch of other data like head injury treatment data, and really, it's a universal thing if we don't actually monitor respiratory rate and end-tidal CO2 aggressively right after the patient's airway is controlled. And then always have your surgical airway gear ready. Speed's key if you need it. I'm not saying that everybody needs a surgical airway, but I'm a very strong believer in my suspicions that if you don't have it ready, you're more likely to need it. So anyway, going into a little bit of depth. So first off, there's a cool article that I think covers some of this first pass success. This is a review article out of EMS World. There's a link in the email. You can take a look. This just came out a few months ago. But they looked at the benefits of first pass success, and they're actually looking at cardiac arrest patients. And what they found is survival among those with first pass success was 10.8%, compared to 4.3 with 2 attempts, 2.6 with 3, and 2% with 4 attempts. So it shows very clear and rapid decrease in survival with even one missed endotracheal intubation attempt. And when you compare all of the first pass success with all the other patients, it was a 10.8% survival versus a 3.6% survival. Now, again, this is correlation and not causation necessarily. There could be other things going on that could complicate getting that airway, that could be related to, independently related to the patient's survival. But this kind of correlation, along with just the physiology and the concept of the longer that patient goes without a definitive airway, and the longer that patient has persistent hypoxia because of that, or hypercapnia because of that, we can imagine that's going to create a bunch of problems for us. So that link's in the email if you want to take a look at the article. It's a quick little review article, so it won't take time to look at that very long. So what we want to do then to optimize our first pass success is we really want to play to win here. We want to use the video laryngoscope right off the bat. We want to use the Bougie. You want it preloaded. We want the tube on the Bougie and ready to go. And then, make sure that you're practicing your technique with this. And there's a lot of success with holding the Bougie, the thumb and index finger on one side, and then between the ring and the pinky finger, making kind of a, shaka hang loose sign. And what that allows is your pinky finger to kind of steer that Bougie a little bit if you need to get a little bit more anterior. But having it preloaded is key, because getting the Bougie in and then fumbling around with trying to get the endotracheal tube on it is not the way to go. The second attempt, if we're doing that, is we want to reposition the patient and then, use that glide scope standard blade for direct laryngoscopy, again with that Bougie. And if there's, sometimes once you get that first look, you can get an idea of what a better position for the patient is. Not to say that we're waiting for the second attempt to get good position on the patient, but we want to optimize the position for the first attempt, and then if we need to adjust that to get a better shot, that's what we're going to do the second attempt. And if we're not getting on the second attempt, what we want to do is we want to move to the supraglottic airway and get that in as quick as we can. And a lot of times, that we'll send trauma patients to the OR with the supraglottic airway in, and let anesthesia swap that out up in the OR. So even in the emergency department, we'll leave that in unstable patients, because we don't want to mess with it and potentially lose the airway, provided it's working. And then always have your surgical airway gear ready. Now, if we're in this pathway and we're getting ready to do the surgical airway, we also want to step back and make sure that we can't oxygenate and ventilate with BLS airways, because sometimes we can get dedicated to a pathway and we can anchor on this feeling that it's going to be an easy intubation and we're going to go ahead and take the airway, find out that it's not. And before we run all the way down to that surgical airway, make sure that you just do a quick double check in your head. Can I really not oxygenate and ventilate this patient through other means? And if you can't, that's the definition of needing a surgical airway. So go ahead with that. And, if you guys want to have some more time on the wearable surgical airway trainer, obviously we have that. We can come out and do reps with that. It's a fun drill for us to put on. I think it's a fun thing to practice. And just getting the repetitions in and getting the skill up is key. After you get the airway, end-tidal CO2 saves lives. It is almost impossible, and I would actually say it is impossible for people to appropriately ventilate a patient once we have a definitive airway in place if they're not using something that limits the ventilatory volume, that regulates the rate, some kind of a metronome, or immediately having an end-tidal CO2 monitor in place which shows us that information. If we don't have that, we universally hyperventilate patients, which causes a metabolic alkalosis. It causes vasoconstriction in the brain. Most of these patients are already having a stunned brain from whatever else is going on in the pre-hospital setting, and that's all going to worsen their outcome. This is such a big deal that we actually got these little tiny EMA end-tidal CO2 monitors for all the medics in Department of Energy so that they can avoid that issue, mainly because they don't have big monitors with them. So having a portable option is key. You guys will always have the monitor. You have the ability to get end-tidal CO2 on and ready to go. But as an adjunct, having something portable like this is key. I have one of these in my kit as well, just for that same reason. I don't trust myself to not hyperventilate a patient if I take the airway. And then always have a backup plan for your backup plan. Make sure that you have that iGel out and handy. Make sure you have your surgical airway kit out and ready. If you're fumbling around trying to find gear in a bag when you need to manage an airway, that is not the time to be looking for that. You should be able to stepwise work through this process for every patient where we're intubating. So you want to have all this gear ready to go. Have spare tubes, have whatever extra stuff that you would normally have right there at hand. And if you have an assistant, make sure that they're competent with you. And when you're training on this stuff, make sure that your partner is there and supporting you. And if you have a BLS EMT who's going to be working with you too, make sure that they know where the gear is, that they're able to support you and involve them, so there's a team effort going on. So take home, summarizing from the first slide, when we're intubating, first pass success correlates with outcome. So we want to make sure that we're optimizing that first pass success. We're going to play to win. We're going to do 2 tries. First, video laryngoscopy with Bougie or the dedicated rigid stylet that comes with the glide scope. And then patient positioning and operator positioning is key. Don't forget the existence of the supraglottic airways, because really what we care about here is time to get to adequate oxygenation and ventilation. How we do that is less critical. We want to make sure that we're getting there fast. We want to make sure that we're also monitoring end-tidal CO2. Hyperventilation kills people. And then make sure you have all that gear ready, because speed is going to be key. Speed is going to be key if you need it. So that's just a quick hit on airways. Hopefully we'll have some more of these short videos to digest and go over other updates. There's a cool cardiac podcast on STEMI equivalents that I want to talk about soon. So keep an eye out for that. Thanks for all you guys do. Thanks for all your hard work. And let me know if you guys need anything, and especially if you want to get some more reps on that surgical airway trainer, let us know. We'll come out and we'll run a drill when you guys are on shift, and we'll play around with it. Take care.